Welcome everyone to today's webinar. I'm Heather Punke, Managing Editor with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Our first presenter is Dr. Philip Eichenholz, President and founder of North Star Anesthesia. After earning his Bachelor of Science degree from Duke University and his medical degree from Duke University School of Medicine, Dr. Eichenholz completed a residency in internal medicine at Parkland Hospital. He completed his fellowship in critical care medicine at the National Institutes of Health before his residency in anesthesiology at the University of California, San Francisco. He is certified by the American Board of Anesthesiology and the American Board of Internal Medicine and is a fellow of the American College of Physicians. Over the past 30 years, he has been published in numerous medical journals and peer-reviewed publications. As co-founder of North Star Anesthesia, Dr. Eichenholz leverages his experience in the field to recognize opportunities for improvement, create solutions, and facilitate communication. North Star Anesthesia is one of the fastest growing anesthesia management companies, currently serving 180 facilities in over 21 states with 2,500 clinicians. Our other presenter is Dr. Solomon Aronson, who is a tenured professor at Duke University and executive vice chairman in the Department of Anesthesiology. Dr. Aronson earns his bachelor's in molecular biology with distinction at the University of Wisconsin in Madison, and his medical degree with honors in research at the Medical College of Wisconsin in Milwaukee. After completing an anesthesiology residency, including a year as chief resident at the University of Texas Medical Branch in Galveston, he completed a fellowship in cardiac and vascular anesthesia at the Texas Heart Institute in Houston. Soon after, he was recruited by the University of Chicago, where he ascended to the rank of full professor and served as chief of the cardiothoracic and vascular anesthesia division for 12 years. In 2011, he received his MBA with a concentration in health sector management at Duke. Among the many research awards and lecture honors received over the past few years, Dr. Aronson has been repeatedly elected from among his peers to be listed on the Best Doctors in America list. Dr. Aronson is the Director of Strategic Business Development for the Physicians Diagnostic Clinic, a physician practice group at Duke, and he has served as chair of the Finance Committee for PDC in the past. He currently serves on the PDC Board of Managers. Dr. Aronson, I'll turn the floor over to you.
Thank you, Heather. I think for those of us in the academic space, it's becoming increasingly obvious that it's more and more difficult to manage the challenges of balancing the goals of supporting and advancing all the academic missions while at the same time being attentive to the responsibilities of just running a business of a high-performing clinical department. We're all aware that there are downward pressures with diminishing hospital resources to support the unfunded or inadequately funded clinical mandate, while at the same time those same downward pressures are realized with greater difficulties in securing traditional available funding sources to support our research efforts and the greater time as well as the greater cost of successfully achieving those resources once they do occur. There are ever-changing and new hurdles to overcome when we try to introduce innovative ways to enable alternative revenue streams. And that having been said, we have been very fortunate at Duke to create and develop interesting and I think very important, if you will, best-in-class processes for changing the perioperative clinical care paradigm. And I look forward to speaking in greater depth about some of these in the next few slides. And minutes ahead of us, things such as a perioperative enhancement team, a preoperative anesthesia and surgical screening process, and other programs that enable us to do care optimization are very exciting and I think have gained great traction. In addition, we have a sophisticated data analytic and data dissemination process to support our academic mission and care delivery processes. We'll speak about our faculty reporting systems and things like that. We've advanced and we continue to enhance our innovative methods to provide quality education programs We'll speak a little about our education highway and some of the other boot camps and preceptorships that we have. And then finally, I'm pleased to present some novel ways to advance our scholarly research endeavors, clinical research organizations with a anesthesia perioperative centric, if you will, point of view, as well as our relationships with the DCRI and some other national entities. So how do we prioritize the academic mission with creating these best practices? To begin, it's important when we speak about an academic mission that's ingrained in all levels of an organization, it's important to understand that everyone must buy in and really truly own the identity of an academic mission. This is as much of a bottom-up as it is a top-down reflection of an organization. It's not easy to obtain this, and to obtain this, I think it's important that culture needs to be received and appreciated by everyone in the department, and the department has an equal obligation to provide back to those invested faculty members. The goal of advancing science in any academic practice imparts that transition from science to providing leading-edge clinical care requires a strong foundation and infrastructure. And that foundation and infrastructure is expensive, and it's something that we in academics are very, very sensitive to. That culture that combines, if you will, a combination of resources and behavior, unfortunately can be a very significant barrier to entry for many departments who are just struggling to maintain or grow their own academic missions. And I hope that we'll be able to share with you how that economy of scale can be realized by this presentation. Next slide, please. As we look toward changing the anesthesia paradigm, and I think it's very critical that we think about ourselves in anesthesia to appreciate the importance of changing that paradigm, particularly as we move from volume to value in healthcare. I think it's really important that we, in the specialty of anesthesia, recognize the need for ourselves to evolve in that ever-changing world in healthcare as well. The role of the anesthesiologist as an individual, the role of an anesthesiology department, albeit a private practice department or an academic department, in contributing to the mission of population health, I think is critical for all of us to consider, and I think we all have to sort of appreciate the urgency of our redefining ourselves in that light. Duke Anesthesiology is taking a leading position to develop perioperative programs to optimize patients in their surgical journey, as well as managing the patients throughout their intraoperative and postoperative episodes along that continuum of the surgical journey. One of the programs that I mentioned earlier and alluded to is a program that we call the Perioperative Enhancement Team. That's an acronym that we use here, and we refer to ourselves as POET. And what POET has done is really taking, much in like of the surgical home concept, the ideals of creating value to the proposition of perioperative medicine by not accepting old paradigms of simply having patients, once declared surgical, to enable them to pass through to their surgical date expeditiously without fully taking into account the need, when appropriate, to optimize patients to better be, if you will, ready to accept the stress and strain of surgery. So things like identifying modifiable comorbidities in this cohort of complex medical problems. Things like identifying patients who are anemic and who would be best served by being diverted and managed in a preoperative anemia clinic, or people who have poor glycemic control who would be best served by being diverted to have their poor diabetes management be served in a preoperative diabetic clinic. We've also stood up preoperative nutrition clinics, preoperative pain clinics. We have a very interesting smoking cessation program that we've launched here, as well as addressing the particular needs of the elderly population, as we all know that they represent a very high-risk population itself. And so the idea here is to not just simply do preoperative testing in the traditional sense of the word, but rather the POET group has identified these patients very much upstream and have taken the proactive responsibility to ensure that their modifiable needs are met before we put them in the pipe for surgery. And the result of that has been very, very impactful and very rewarding. I would just say in the spirit of time that our transfusion rate, for example, in patients that are undergoing joint replacement surgery or spine surgery, has decreased significantly in the last few years since we've launched our preoperative anemia clinic. And we are eager to enjoy the same kind of results in some of our other management situations. And with that said, I look forward to speaking more about this in the Q&A session, and I will pass the baton over to my partner.
Thank you. So really, what you're hearing Dr. Aronson describe is that anesthesiologists are taking a much larger role throughout the entire perioperative continuum. And in a sense, that's really changing the entire anesthesia paradigm. Anesthesiologists managing the patient experience in its entirety for the hospital. And that just doesn't just happen, right? Because there are a significant number of stakeholders that are at the table, right? And who are we talking about? We're talking about the hospital administration and the needs of the hospital. We're talking about the surgeons and their needs. We're talking about the OR nursing staff, and we've got to be cognizant of how we can get them to function well. And certainly, and not to ever be forgotten, we've got to remember that the anesthesia staff has to be at the table also. But what's so pivotal about all this is that anesthesia is in the house, as we like to say, 24 hours, 7 days a week. And we know all the stakeholders, and to a great degree, we understand what their needs are, and we have the ability to bring the stakeholders to the table, right, to have create the kind of processes to have success. And so really what we're saying is that anesthesia has increasing importance in aligning the interest of all the different stakeholders so that we're serving the hospital's needs with the patient in mind always. And that just doesn't happen. There's a lot of conversations that have to ensue and a lot of processes that need to be established. And to do that, we found that it always starts first with great leadership. And right away you're facing a conundrum in the academic center because if you look at academic centers across the country, about half the chairmanships are open right now, and that's kind of the canary in the mine that's telling you that this is a difficult task and hard to find the right leaders, and so you have to identify a great chief anesthesiologist or chairman, and we believe strongly that they need to be aligned at the hip with the chief nurse anesthetist, both of whom are working together as a team with the idea that they have ownership in the academic institution or the hospital. That has to be their thought process from the beginning of the day to the end of the night, and then they have to get buy-in from all the different stakeholders in the team. And so how do you create that kind of team, and how do you make it happen? And we have found some things that have been very successful for us. Number one is that after we select and evaluate and continually evaluate our leaders, we supplement them with regional leaderships, because lots of times there's tough conversations that need to happen, and we found that having regional leaders that can come in and facilitate conversations, support our leaders, sometimes pass on information, sometimes listen for tough conversations. We're all working together as a team. And then certainly you got to have accountability and best practices, and you can't just assume that a given chairman has a skill set. He may be a great researcher. He may be a great clinician. but that doesn't mean that he or she was necessarily trained in leadership skills. And so we have created North Star University. We bring our leaders back. We work on communication skills. We work on who we should be having conversations with, the CFO, the CEO, the COO, the CNO, our surgeons, and what kind of reports should be given. And I would say, finally, very importantly, how to listen and how to follow up. And that is all part of creating the leadership to change the anesthesia paradigm. If you don't do that, right, then we face the high cost of complications. And when we used to look back and say, hey, surgery, we make 70% of our profit, and it's a huge profit center for the hospital. And if we have a few complications, well, we have difficult patients, and every patient is unique, and things happen, right? But increasingly, there's an awareness that we're going to be reporting out our complications and their costs associated with them. Here we show on the slide $11,600, but the costs are so much greater than that, really. And so a number of studies have shown that if we establish protocols and have people follow them, we can really get to the point where we're standardizing our approaches, and there's actually nothing wrong with that. In fact, that's a good thing. And I like to say that that there's nothing wrong with providing a Starbucks type of experience for our patients and our surgeons. That doesn't mean that every patient's the same, but it does mean that we need to standardize our approaches, and we'll talk about how we do that and make sure that in the end people are getting value for the care that we're providing. So how do you go about doing that? That just doesn't happen. And so we're going to tell you some of the things that we have used and we think that we've had great outcomes with. The first is that we've been able to use financial incentives to hold our faculty, our anesthesia staff, to be accountable for a service-driven culture. And what does that really mean? What that means is the following. We take a team-like approach, and we tie compensation, part of the compensation for every provider to perform as a team. So we don't individualize particular anesthesiologists or CRNAs or anesthesia assistants, but we do say to the team, we define that these are the incentives that we're going to accomplish this year. And we usually say that they're going to be about 8 to 10 different metrics, and we divide them up in terms of clinical outcomes and operational metrics. So if you go beyond 8 to 10, it gets a little hard to keep track of, although we're tracking lots and lots of different metrics. But if we hold people accountable financially to 8 to 10, it is amazing the outcomes that we get. So what we say is that these metrics that we establish, they need to be reachable, but they have to be a reach. And so we'll divide up, for example, on operational metrics. And Dr. Aronson, gave you a sort of an insight into what they're doing at Duke, and it should be done across the board in this country. We need to have very well-run preoperative clinics. And he talked about how they're trying to evaluate patients to prevent complications. We'll also tell you that those pre-op clinics can be used to bring in social workers and to bring occupational therapy, bring in pharmacy, so that we can try to make sure that upon discharge, patients are prepared. And that's when the family members are there, and so we take a very algorithm approach to making sure that the patients are prepared before surgery. And when it comes time to surgery, right, everyone now expects that the operating rooms are running a very lean type approach. And what does that mean? You talk to surgeons and they all want to start on time, right? So we've got to document that we are starting on time. We've got to be ready. We put money on the line to make sure that we get the on-time starts, that we don't have case delays, that our turnover times are appropriate, and that we get that type of OR throughput. We could go on. We have probably over 30 different types of operational metrics that we're looking at. But listen, I want to very much point out that quality is of key importance too. And so we also put money on the line for protocols for central line placement, for antibiotic administration. And very importantly, I got to note that surgeon satisfaction and patient satisfaction are of key importance. And we'll put money on the line with that, and it will make people pause and make sure that not only are you delivering great care, but that the patients perceive it as great care. And that is really, we found a great part of succeeding. I got to tell you, though, that it's not all just about financial incentives. And I say the next part a little bit tongue-in-cheek, but I am a Duke graduate, and when I was a medical student, the key to success was to have a well-cleaned coat that was buttoned, that you knew how to answer the questions correctly, and you treated the patients with respect. But there was not a big emphasis at the time on team play and on overall culture. And I think that there's a much greater realization across the country, and I certainly see it when I go back to visit at Duke. You can't avoid missing all the signage that's talking about how do we get the core values and the culture. And so for us, we spend a lot of time before we even get started in a given academic institution or a given hospital. We'll spend an entire weekend working on how do we instill core values. And those core values, and if we could advance the slide, we talk about that we need to be very accountable, that we need to strive for service excellence, that, and I made note of this before, but the care has to be perceived as compassionate, and we have to treat not only the patients, but certainly all the staff with mutual respect. And I was struck this morning, Becker's is pointing out a study that just came out that when a surgeon has more patient complaints, there are also more surgical complications. And so that cannot ever be de-emphasized. And at the end of the day, anesthesia needs to practice the leadership to be accountable, and together that we work together as a team. And how do we besides talking about people, talking to people about these cultures, how do we really make it established? And the key thing we believe is that what's in it for you, and we have to talk to our people how you have a sustainable model and how it's going to work for them, and consequently therefore work for their surgeons and the patients in the hospital. And very importantly, we think that we need to recognize people, and we do that in our company functions. We do it at the hospital level, and we keep that recognition ongoing. And it's certainly, for the people that are high performers, they deserve that recognition. But very importantly, it makes the people that are not necessarily high performers realize the importance of this. And for us, we found, and I think that's clearly the case now at Duke, and to succeed across this country, we do have to get the right culture in place. The next thing, though, so I've talked to you about leadership, and I've talked to you about financial incentives, and very importantly, the culture. But you've got to measure what you're doing, and that's the only way. You've got to define it and have a measurement tool. And I'm going to turn it over to Dr. Aronson because they're doing some really interesting things at Duke, and very impressive, and I want him to have an opportunity to tell you about that.
Thanks, Phil. Indeed, again, a very, very critical theme to everything that we're speaking to is the role of the anesthesiologist in this new world that we live in, and the world that we're going toward, is to think about how we create value, not just the individual patient experience, but also to the population as a whole. And in order to do that well, just like it is essential for any company or industry to have systems in place to track their productivity, so too do we believe it's critical for our department and our specialty to have metrics that we can define and measure and develop those systems whereby we can track them. Based on, obviously, those metrics, we can use that to enhance our abilities to continue to do better, to monitor how well we're doing, and to use that experience to stretch our goals even beyond that. So we're constantly pushing the envelope to enhance value. At Duke, we put together a system called the Faculty Developed System. It's a system that is built on the backbone of a very large and robust IT infrastructure that we have within our department. I will be very proud to share with the group that we actually have 12 people in our department who are just dedicated to IT. We have a very sophisticated group who build to not just data management systems, but help us develop all kinds of novel systems that allow us to track and display all the metrics that you see in front of you. So we measure and provide to our faculty clinical metrics. The classic things like first case on start times and room turnover times for sure are measured and provided so that we all can compare ourselves to our peers and each other. But moreover, beyond that, we've introduced some other, if you will, derivatives of important quality assurance and efficiency clinical metrics, and we display that in the Tableau kind of methodology, not just to each faculty so they can keep track of their own performance, but to the division chiefs and to the senior leadership in the department so we can constantly be monitoring and measuring and managing accordingly. Of course, we're an academic department, and our goals are beyond just efficiencies of care, not to underscore the importance of that, but we also want to keep track of other things like education, mentoring, citizenship, other things that are important to faculty development, and certainly research, if you will, productivity. And all those are built into this system and have very, I think, sophisticated algorithms that will enable individuals to track themselves and also for their immediate supervisor to monitor them and make appropriate comparison. This system has been highly received within our institution, and we're at this time actually sharing that with other departments within the greater Duke system. And it's something that we're obviously very proud of.
So what we're really seeing here is that you got to get the leadership, you got to get the culture, you got to get the data, but then you need to also step back and ask questions in a very non-emotional way, saying, really, are we doing this in the best way possible, or are we just doing what we did yesterday? And we would tell you that there are some incredible opportunities to mid-level providers to optimize profitability, and very importantly, let me underscore this, optimize the academic mission. So there is certainly, I think, an overall understanding that with value-based care, we're going to have an increasing shift to care team models, and the economics of that make that very obvious. We can have people practice at the top of their license, and we can take care of the clinical load that is definitely there in every academic center, but then very importantly, we can prioritize the cases that are great learning experiences that we need to provide for our academic anesthesia residents and our student CRNAs and anesthesia assistants, so that we are trying to really make sure that we're providing a great learning experience, and at the same time, for big, large institutions like this, taking care of the clinical demands that we have to do and have to do well. And cost containment will continue to be a priority. They certainly, despite everything that's happening, and I say that with a little bit of humor, but despite everything that's happening in our world, there is also an acknowledgement by everyone that we're going to have to find ways of taking care of people in a very cost-efficient manner. And we believe that an increasing shift, and I'm going to talk more about this, of using CRNAs and anesthesia assistants in certain areas of the academic center is one way of saying, okay, here's a new model. So, Saul, what are you seeing? Is this trend unfolding at Duke, and what are you seeing on that end?
Yeah, thanks, Phil. I believe that we are equally sensitive to those realities that you just spoke to. We have within our greater department a community division. It's a very important division within our department. It's a very rapidly growing division within our department. And within that division, we, of course, understand and respect that the opportunities to grow and generate, if you will, the necessary resources for us to support our mission are very dependent on the flexibility that they require to grow. And that, it's certainly, we're very sensitive to the fact that one size shoe does not fit all. And we, through our community division, have greater flexibility to address the cultural needs within the community at large. As we certainly, try to put all this together, it's certainly true that we always strive to sort of balance the academic experience with the clinical experience, and it's certainly true at Duke as well. I spoke earlier about having something that we call the Education Highway. That's an advanced educational program that enables our sharing of educational programs, whether they be lecture series or panels or live demonstrations of techniques. Even remote simulation scenarios are accomplished through this online distant learning platform. But in addition to that, we also have introduced many on-site learning programs, such as preceptorships. We even have a boot camp. Phil spoke to leadership importance earlier, and we focused on the importance of that as well at Duke. And a simulation scenario that we can custom to anyone who wants to participate. In general, it's our philosophy that we want to train everyone to achieve at the height of their license.
So, in a sense, that follows completely with our experience, that one size, we say, does not fit all. And we want to tell you just about a unique experience we had. We came into the Detroit Medical Center, which is an academic center that faces all the challenges that we've talked about. And in a sense, you'll read about Detroit being a place of renaissance, and they're facing huge challenges, and it makes people ask, okay, how do we do this better? What's new? And in Detroit, we have a very acute trauma center in Detroit receiving. We have a quaternary academic center in Harper-Hudson. We have an urban large urban hospital in Sinai Grace, and we have a suburban hospital out in Huron, and surgery centers. And so we came in with the approach that, okay, we've got to cover lots of sites. We've got to make sure the academic mission is met, and they were very clear that that was of utmost importance, but we've got to do it in a cost-efficient manner. So some sites you have with just physician only. Some sites, and I want to note that when you're training anesthesia residents, you have to have one anesthesiologist directing only up to 2 anesthesia residents. But that doesn't mean that you have to do that across the board, right? So there are other areas where we have one anesthesiologist directing up to 4 nurse anesthetists. And there are other sites, including GI and non-invasive radiology and cardiology and pain, where we're extensively using CRNAs working hand-in-hand with surgeons. So we're trying to do this in a very cost-effective manner in a complicated system, making sure that we provide the best clinical training for the residents, both the CRNA students and the academic anesthesiologists, but at the same time, we've got to be cost-effective. And so look outside the current model that you may have and ask the question, okay, how can we do this different, or are we just doing it the way we've always done it? And so we took that approach, and we'll tell you more about how we've succeeded. But as we did all this, that prompted us to say, okay, is there the opportunity to do this even better? And I think you're seeing this unfold across the country. You're seeing academic centers partner with private not-for-profits, or even some for-profit systems. And I don't think this is going to go away. I think it's going to trend continually on, because what we really need to do is bring the expertise that we all have to bear and say, okay, what can we all bring to the table and how can we make this work? And that's really the genesis of why we're here today on this webinar. We're trying to figure out, and we think we have some great ideas of how we can take what North Star has done and take what Duke has done and provide that kind of experience and opportunity for a lot of other academic centers. So I'm going to turn it over to Dr. Aronson, because they have done some really unique partnerships, and I think that you all will find this very interesting and revealing.
So clearly, partnerships are important. We believe that we need to build those partnerships internally as well as externally. Within that domain, what Duke has recently done to add to its already pretty robust fellowship program. We have fellowships in cardiac, neuro, pain, critical care, regional obstetrics, pediatrics, and hyperbaric medicine. We just recently launched a perioperative medicine fellowship. And I speak to that not only because I think that is unique. I believe there's only about a half a dozen or so in the country that exists right now. But importantly, our perioperative medicine fellowship is in collaboration with the University College of London. University College of London, of course, has been a part of the NHS for the last several decades and has great experience, wealth of knowledge in the area of perioperative medicine, an area that we're only now beginning to touch in this country. And so the collaborative opportunity to work with a true leader in the field is underscored by that. We have built many important programs with respect to our clinical trial interests, not only because of our relationship with the DCRI, but also just to coalesce a number of practices, albeit they academic or non, to build a robust foundation for clinical trial research. You can move the slide. So, to speak of collaboration and the importance of building those bridges and growing those collaborative relationships has always been important. I think it really is, and it has never been as important as it is in today's environment. We, in Duke, strongly subscribe to the principles of teaching and leadership for everyone and from everyone. And I think that's important because we learn as much from our colleagues in the private sector, in our community division, as we would hope to teach anyone. This is certainly true as much as it is with our outside relationships. And it's our hope that we continue to share our strengths with others that will enable an academic progress to take advantage of those opportunities that would otherwise not exist if an institution or a department would be dependent on their own organic growth opportunities. Things like our IT systems, our advanced education programs to disseminate those best in practice protocols, albeit they before the operation, during or after, for the continuum of care at any institution, I think is core to our mission, and we're happy to be a part of that.
So what we've really tried to do is say, let's take best practices across the board, and we're trying to work with Duke in a collaboration to say to other academic centers, how can we help you? Because we went into Detroit, as I told you, and Detroit Medical Center said, listen, we've got great needs here, and we're going to consider and then follow through with outsourcing the management of an academic department. And so we went in there and we said, okay, we're going to take responsibility and accountability for the entire perioperative management of surgical services. And we did things like create a joint leadership team made up of anesthesiologists and CRNAs that meet every 2 weeks. And to provide great learning experiences, we had the chief residents run these meetings to bring up concerns and other issues and ensure that the training opportunities are being shared fairly among the residents and the student nurse anesthetists. And then we put in place the entire process, right? So we established the pre-op clinics, we established the processes to make sure that the operating rooms worked in a very lean fashion. And as I've told you previously, we took responsibility for post-operative care and pain and even upon discharge. But hand in hand with that, right, of great perioperative management, we had to make sure we had great academic leadership, and we put funding and resources into making sure that we were rewarding physicians who were publishing and that there was enough resources to support research coordinators and conference costs and all the other attendant costs that help build academic leadership. And certainly you have to make sure that there's great residency program management, and we leverage clinical leadership from across the country that have led to great improvements in the Detroit Medical Center residency program. And really the result of that is that we're seeing that more applicants to our residency program than ever before. More residents are opting to stay at the Detroit Medical Center. And I think most interestingly, more residents are choosing to return back after completing fellowships afterwards. And I think those are signs of a very healthy academic mission. And also, if you look at what is happening in Detroit Medical Center, we're covering more sites in actuality with less people at a significantly less cost. So we are doing what we need to do, which is make sure the academic mission flourishes, lower the cost, improve the quality of care. And as much success as we've had there, that certainly prompted us to say, are there opportunities elsewhere, and who can we partner with, and can a partner bring more to the table in addition to what we're doing? And I think we have a resounding yes, because I'm going to just turn it back over to Dr. Aronson and let him talk a little bit further about some of the great things they've done at Duke, and I'll certainly emphasize once again that we want to be able to take what we've learned, what we've built up, and create other opportunities for other academic centers, because certainly one can try to do this organically from the ground up, but there's a great cost involved in time and certainly challenges. And we found that certainly if we can get help from others to establish things and put it in place, then it's certainly in the end many times it was accomplished at a much lower cost with a greater outcome. So I'm going to turn it over to Dr. Aronson to kind of finish up here and really highlight how Duke has been able to succeed on this end.
Thanks, Bill. And just sort of to recap and I guess open it up to discussion. Again, we've taken a very proactive approach to managing all the missions within an academic department. They include our day-to-day needs to always ensure, you know, the most efficient and effective service, as we all are familiar with. But in addition, we've invested heavily in the future, looking forward to a much more risk-bearing healthcare world. We've created programs such as POET, the Perioperative Enhancement Team. We've invested heavily in seeding our IT infrastructure to support the quality as well as data analytics that are necessary to do that effectively and meaningfully. We've developed novel educational programs that enable us to more effectively and efficiently transfer information. And we continue to invest heavily in our research mission by building relationship bridges, not just within our institution across departments, but also taking advantage of national clinical research organizations to ensure that we're continually able to meet the demands of a clinical trial world. all of those programs, I'll be their best in practice clinical processes, educational, novel, if you will, programs or research, knowledge and expertise are things that we're looking forward to sharing, if that makes best sense going forward.
Yeah, so I would say that when I look at the landscape for anesthesia, huge challenges, right? Great clinical loads, lots of expense attended with it, a challenge in succeeding on the research and academic mission side, and a great expectation that protocols like enhanced surgical recovery be put in place. And when you look also the fact that half the programs in the country don't have a leader, then that means that we're really struggling across the board. And that's why we believe we've taken this kind of novel approach of taking the best in class that Duke has established and the best in class that North Star has established, and say, how can we certainly work with other academic institutions, thinking outside of the box in a new paradigm approach to make sure that we reach the objectives that we all want to reach. And I would be negligent to say if I didn't note that certainly a lot of these practices can't be applied to other facilities, and we're certainly doing that in other facilities because we all go through a final common pathway of best practices, best outcomes. But we so appreciate the people that have taken time out of their day to listen to what we're doing, and perhaps to think a little bit outside of the normal way of doing things and consider whether we could help them. And we have a very exciting future in front of us, and we obviously there'll be challenges, but we hope we can succeed. We think we can.
Great. Thank you so much, Dr. Aronson and Dr. Eichenholz, for that fantastic presentation. We will now begin today's question and answer session. As a reminder to our audience, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We'll try and get through as many questions as we can as we have time for. So Dr. Aronson and Dr. Eichenholz, I have one question here that could be for the both of you. The question is, how receptive are hospital administrators to let anesthesia have more influence in the perioperative continuum?
Bill, you want to start or you want me to jump in?
I'm going to let you jump on that, and then I'll follow up.
So I think the answer is very receptive. It is an unmet need in many institutions, and in institutions where it's not realized as an unmet need, it's probably because they haven't had a chance to really, think about it in the broadest context that we are now asking them to think about it. The idea of being able to enhance throughput is well established. The idea of being able to prepare a patient optimally for surgery, particularly in a value risk bearing world, is critical, and many hospital administrators don't know all of the options available to them to do that. When we in anesthesia can introduce to them processes that will enable that value proposition to be better realized, it's received very well. I will just simply say anecdotally that at Duke we've been doing this within our POET and some of our other optimization programs now for going on 4 years, and it's coalesced to really change dramatically the paradigm in our intake processes for surgery in such a way that we're about to launch a very important institutional change in that process. The idea of having a patient be declared surgical and going to surgery without taking into consideration the need to make them surgery ready is no longer an acceptable reality in today's world. We see this in pilot programs such as the CJR and CMS, and it is our opinion that that's only going to grow, and it is our realization that administration is very appreciative and very willing to receive input from anesthesia to enable that to happen in a way that benefits everybody.
So I would just say that it's a vacuum, a space that is so needs to be filled, And when anesthesia steps up to the table and starts filling it, that's how you create that partnership between anesthesia, between the clinicians and the hospital and the surgeons. And it's always well received. It takes a lot of effort, takes a lot of throughput, takes a lot of listening, a lot of communication. But it, in a sense, really is the new paradigm, and that's where that is the only way we're going to have success.
Great, that makes sense. Thank you both. This next question I'll direct to Dr. Aronson. It is, how will academic medical centers combat the need for research investments as we move toward value-based care?
I think we're going to need to be more creative. We're going to simply need to be more innovative. The realities are that those available funds to support the academic mission are decreasing. And if we are to continue to simply rely on the traditional ways to support that mission will deteriorate. We've been very proactive. We've been very, in some respects, even entrepreneurial here at Duke to ensure that we can continue to generate those resources to enable that mission. But that said, I think it is as simple as really moving the paradigm of the way you practice forward and not being locked into the sort of traditional ways of practicing. I think in some respects we're all victims of our own success. For decades we've been fortunate to be in a field where it's been not as challenging to create that margin as it probably has been in other specialties. I think that reality is shifting, and I think anesthesiology especially needs to move very, very aggressively and very proactively to a new world order. And I think with that ability to support mission is going to come. There are other realities. There's an expensive infrastructure to confront, and we have to be creative enough to share, if you will, comparative advantages among and across, if you will, departments and institutions, so that we don't have to live in our own silos and be victims of the expense of supporting those individualized silos as well.
So I think what you heard most importantly from Dr. Aronson is that we can't live in our silos and we need to collaborate. And I think that what we're trying to do with Duke and North Star together is to provide a collaborative experience to allow and enable research opportunities that otherwise would not happen.
Great point. Thank you both. This next question I'll also direct towards Dr. Aronson. What technology investments are the first to consider if we are going to begin larger investments in that area?
I'm not sure I fully appreciate the essence of the question, but I think what would be first is dependent on the institution. I think everybody has their own sense of who they are and where their gaps are, and I think it's reasonable to suggest that there need to be a gap analysis, and with that to understand how to best apply any of those technologies that may exist and how to apply those technologies that may exist to serve those priorities that make best sense for the institution. The point I think that I made earlier would be the same point I would make now, which is the opportunity to collaborate in order to achieve a way to fill those gaps is something that has to be considered in a much broader context than an individual sort of myopic context.
Great. Dr. Eichenholz, anything to add there?
No, I think he hit the nail on the head. There's different resources at different institutions. We may not all at every institution, nor should we necessarily have the resources to employ 12 different people in IT, right? That's all part of what we're trying to do here, is to allow the collaboration so that we can get best practices put in place and therefore get the data that we need so that we can measure and hold accountability. And that will all unfold uniquely at each place. but we will not succeed unless we all figure out how to work together to a great degree. And so I just want to add, we're intently serious about the opportunity to come and visit with different institutions and show them what we've done and listen to them and see if we can come up with a solution that may potentially work for them. We think that there's a huge need, but it will require people to think outside of the box, but also to realize the opportunities that are there. And the opportunities are tremendous in terms of finance, in terms of furthering the academic mission, and in terms of collaboration.
Awesome. All right, we have another question coming in, which could apply to the both of you. How are you giving residents opportunities to participate in all aspects of the OR?
Well, I mean, it's a part of our sort of curriculum within Duke to graduate their level of responsibility in just a tactical and nuts and bolts way. Things like running the board, if you will, or managing schedules, albeit during the day or at night, is a continual graduation of role and responsibility. Moreover, we have begun to build into our curriculum some of the things that I spoke to earlier as they pertain to the perioperative medicine fellowship. That's not just running the board, but it's really to be able to sit in the room and intelligently speak to all of the needs of standing up a preoperative anemia clinic or a preoperative smoking cessation program, doing the financial analysis to ensure that it's viable and responsible, being involved in the operations and tactics, learning how to do workflow study analysis so that it's practical. All of those, if you will, basic managerial and operational skills are also graduated as the residency and even fellows evolve along their continuum in education as well. And it's a very central part of our educational, if you will, deliverable here at Duke.
So I would add those things are critical, and I would also say that's why you need to look at your model so that you have everyone practicing at the top of their license, in the sense that we can have CRNAs and anesthesia assistants participating in regional anesthesia. We have them participate in cardiac cases, liver transplants, heart transplants, but we got to always make sure that the residents and the student CRNAs and anesthesia assistants get a great opportunity for clinical exposure to those areas. At the same time, use your people to make sure that we meet the clinical needs that large institutions like this have to meet in a cost-effective manner. And that allows then for your residents and your faculty members to participate in research or participate in the areas that Dr. Anderson just outlined. That's how you end up with the leaders of tomorrow, and that ends up with a really rock-solid, flourishing academic department that is both meeting its academic mission and economically viable.
Great, that makes sense. Thank you both. Unfortunately, that was the last question we have time for today. I want to thank Dr. Aronson and Dr. Eichenholz for their excellent presentation, and to all of our audience members for participating today. Enjoy the rest of your day, and we look forward to having you join us on future webinars.
Thank you.
Thank you.